Welcome. Thanks for including our work in this inspiring panel and providing my colleagues and I the opportunity to share some of our findings from the project Borderlands of Living, which is an ongoing research project at the Aarhus University. I will start by setting the scene. Please shift slide. Our research team in front of the neurointensive care unit where this work is situated. Our project is concerned with the professional practices of clinic and research related to patients perceived as unresponsive following acquired head injuries. The talk is based on a particular part of the ethnographic fieldwork taking place between May 2019 and January 2020. In medical terms, these patients are either diagnosed with unresponsive wakefulness syndrome or at a minimally conscious state. In the clinic where we meet the patients, they've just been referred from acute intensive care. They are commonly still ventilator dependent, and their treatment in the unit is focused on specialized early neurorehabilitation to support their recovery of consciousness and assess their potential for further neurorehabilitation. It is often expressed by the staff that all patients who come here are given a chance to show their potential through the work they do with them. The duration of the stay in this unit is commonly between a few weeks to 6 months. Depending on the ongoing assessment, patients are transferred from here to further specialized neurorehabilitation or to standard care at a municipality nursing home. Our objective for this talk is to highlight the process of ascribing personhood to unresponsive patients, partly because it helps us to understand how personhood is constructed in the realm of liminality, and partly because we render this important from a societal point of view, as ascribing personhood to the unresponsive patient enhances the ability of the healthcare professional to understand potential signs of contact, consciousness or awareness as systematic responses, which may indicate a potential for further neurorehabilitation. Please shift slide. I would like to invite you into the setting and introduce you to the subtleties involved in determining consciousness by sharing an observation from the fieldwork. Before entering Peter's room, a young man aged 21 who suffered a severe head injury from a fall from the first floor window, Lise, a nurse in her mid-30s, states that she no longer expects to receive a response from Peter because his condition is so bad. She explains that earlier on there have been islands of contact where they could communicate with him. This was done by asking him to look up when he meant yes and down when he meant no. But this ability has disappeared and they no longer see improvement. But that's why it's good to work with someone who is a bit more inexperienced and still open to the fact that something might happen, Lise says, pointing to her colleague Judy, who takes part in the care. One of the first things Judy notices after saying hello to Peter is that he has a visible boogie in one nostril. Judy explains to Peter that she would remove it, and while doing so she acknowledges that it seems uncomfortable to him. A little later, during another care routine, she asks Peter, "Does it hurt?" Peter releases a big sigh. "I know you don't like it," Judy responds. In this small excerpt from the expectations of the patient's inability to interact in a meaningful way by signaling with movements of the eyes is contradicted by adjusting to subtle reactions and sounds coming from Peter, indicating that the nurse's actions do affect him. This exemplifies an everyday care interaction where personhood is ascribed through social practices entrusting certain preferences, valuable relations, moods, and sometimes even humor to the patients in this marginal borderland of living. Please shift slide. Clinically speaking, these patients are, as mentioned, categorized as either being in a state of unresponsive wakefulness syndrome, what is commonly referred to as vegetative in our field, or in a minimally conscious state. Both these categories, which are more thoroughly explained on the slide, reflect an ambiguous state of consciousness that creates clinical uncertainty about the potential for rehabilitation. Such categorization of the patient's state of consciousness is extremely difficult, partly because it may fluctuate over time and partly because the prognosis depends on a number of individual specificities relating to such factors as age, neuroplasticity, location of brain damage, and the origin of the injury. Still, these categories are important for the clinical decision-making around the trajectory of the patient. Please shift slide. To zoom in on the relation between the interpretation of states of consciousness and the constitution of personhood, we will explore how healthcare professionals use multiple technologies in their clinical interaction with these patients and how these technologies are involved in the social practice of prescribing personhood to the unresponsive patient. In our research, technologies are understood in the broadest sense and range from brain scans to close monitoring of vital functions, including the clinically based sensory practices to assess the ambiguous states of consciousness. Monitoring serves several purposes, as the unresponsive patients also have a multitude of medical needs to be attended to. Monitoring helps secure the survival and stabilize their physical condition. Alongside this 24/7 monitoring enables the healthcare professionals to use the variations of such measurements as indicators in their interaction with the patient, whereby they are supporting their practice of personhood. An example of the social practices involved in the close monitoring is found in the actions taking place around Julia, who has been admitted shortly after a car accident. She is a woman in her mid-20s. Here, at the beginning of her trajectory, the healthcare professionals think that she is physically responding to the shock from the accident, as her temperature and heart rhythm are very unstable. As they are closely monitoring her to adjust her medicine and initiate other kinds of treatment, they use the fluctuations specified by the monitors as an account of emotional reactions to different sorts of stimuli. Let me exemplify. Please shift slide. As part of regaining the best possible physical functions, she has to wear specially designed footwear, very alike to foot splints, to ensure that she may eventually be able to walk on her feet again, even though they've been immobilized for a longer period. Having been moved from the bed to the wheelchair and put on the foot splints, Alice, the nurse, notices on the monitor that Julia's pulse has reached 110. This is probably because she has been moved to wheelchair and being disturbed. And she got these splints imposed on her. She doesn't like them. The nurse is monitoring the interaction with Julia and interpreting the rising pulse as a reaction to the activities and the discomfort. In this way, the nurse is not only observing a physical change, but is ascribing personhood to Julia through her interpretation of Julia's reaction as an emotional response to the physical discomfort. Please shift slide. This observation is feeding into the conceptualization of personhood that we are orientating us towards when drawing on anthropologist Daphne Schiavates's definition of personhood as something to be recognized as a social, embodied, and sentient being. With this definition, we seek to trace personhood as shaped through the interaction between the nurse and the unresponsive patient, namely that the patient is expected to be social in terms of responding to inputs from others, embodied, understood as capable of performing certain bodily tasks, and sentient in the sense of having self-awareness and some continuity in regard to one's life history. This expectation of a manifestation of personhood seems fundamental for the negotiation of cues, emotions, and responses occurring as the healthcare professionals are seeking to determine the patient's state of consciousness. When contrasting observations from Peter and Julia's trajectories, we may see this more clearly. Please shift slide. In Julia's case, hardly anyone believed in her recovery in the beginning. Jackie, a nurse being only a few years older than Julia, describes what Julia does with her mouth is not a good sign. Instead, it indicates that the reptile part of the brain has taken over. Therefore, Jackie does not believe that she will recover. Rather, this signals that she will become a vegetable. But on the other hand, she has a strong body, Jackie says. Another one of her very experienced colleagues shares the same opinion. I do not believe in it. But one should never extinguish hope. She claims to have seen something like miracles in the unit before. This characterization of Julia as a patient without much potential is supported by those subtle observations done across the disciplines working on her recovery. For instance, in a caretaking situation, where one of the nurses tries to interact with Julia in connection with having to check up on her diaper. Julia, I just have to see if your diaper needs to be changed, the nurse says before checking up. And then to make the interaction more mutual, she asks, can you just look up here, please? Lisa, the nurse, awaits a response. Nothing is happening. When being outside the room, Lisa explains, I don't think there is contact. If she looks me into the eye, it seems random, like a coincidence. Working with establishing eye contact and using the movements of the eyes as a tool for communication is very often part of the early neurorehabilitation, as the patients are silenced due to the tracheotomy and commonly they are challenged by an inability to move. But focusing on the eyes to establish a clear sense of the patient as a sentient being might also occur spontaneously. This happens in a situation where one of the other occupational therapists is about to make Julia ready for the transfer from bed to wheelchair when she suddenly opens her eyes. "Oh, it's good seeing your eyes," Rahim immediately responds, but without evaluating whether this was a sign of conscious presence. Please shift slide. Simultaneously, Peter is still being monitored, but with the before-mentioned negative anticipation that he's not capable of re-establishing the previous use of eye movement as a communication tool. They still notice when he's spontaneously looking at someone, like when one of the younger nurses is gently rubbing lotion on a sore area, and he's then opening his eyes. "Are you watching me, Peter?" the nurse jokingly responds to make him aware that she is noticing the interaction. In another situation, Peter is being mobilized. Sandra, the physiotherapist leading the activity, is asking Peter to look up for yes and down for no. After having asked him to do so, she waits for Peter to move his eyes. It does not happen. She continues the activity and tries to make Peter respond again. "If you can hear us, you have to show us." She instructs him to either blink or open his eyes. Still, nothing is happening. A little later, she tries again. "Try and look at me," she encourages him. Peter seems asleep. She touches his arm and the cheek, and then she repeats the instruction from before. Now her head is even closer and she seems very observant. Something happens. Maybe the left eye opens up a little? Says Sandra, as if trying to decide whether Peter was actually following her instruction. Later, Sandra concludes that he did not succeed in opening his eyes. He clearly did not show himself, as they sometimes say, when referring to the actions necessary for the patients to perform to convince the professionals that they are consciously responding. Our argument is that such assessments of the patient's state of consciousness, determined by their ability to relevantly respond, is strongly influenced by how the professional ascribes personhood to a particular patient. I will try to show you how. Please shift slide. Perceiving and approaching the patient as a person with a life history reoccurs time and over again in the field. For instance, in the introduction to the patient before entering the patient's room. After having mentioned the most salient physical issues, a short characterization of the patient as a person takes place. In the case of Julia, some of the first things mentioned is that she is a mother with a young son. The whole family was in the car when the accident happened. The car was hit by a truck just as she has loosened her seatbelt to locate the pacifier for the son. This was why she was so badly injured compared to her husband and their son. When talking about Julia, the family is always in the forefront. Her motherhood and relation to her young child is a main concern. Her relatives are included in a recreation of her life history, and the healthcare professionals both listen to the stories of her previous life and observe the different levels of involvement. Prominently is Julia's mother-in-law, a very energetic and young-looking woman with a close relationship to her grandson. Julia's mother-in-law is highly present at the unit, trying to visit every night to give Julia a neck and foot massage. This frequent presence of the mother-in-law, husband and son manifests Julia's identity as a mother, which for the healthcare professional becomes a way of ascribing personhood to Julia. Her life history also continues through the actions occurring at these visits. As an example, her mother-in-law is keen to establish this continuation of Julia's identity as mother. With her grandson on the arm, the mother-in-law shows him a photo with him and his mother together. She points to the pictures and says, "This is your mother." Then points to Julia in the wheelchair, saying, "This is your mother." She repeats this movement many times, seeking for him to establish this connection. The personhood dynamically established around Julia carries evaluation as one who deserves a chance, meaning that she should be referred to further neurorehabilitation. From the perspective of her mother-in-law, Julia is a fighter. She anticipates that Julia is capable of working her way through the obstacles that reduce her ability to make contact with the surroundings. The healthcare professionals charged to make the decision are of the same opinion, that Julia deserves a chance, even though she has not yet shown clear signs of consciousness. The active and hopeful personhood ascribed to Julia influences both relatives and healthcare professionals' understanding of a potential for neurorehabilitation. The social practices involved in constructing personhood around Julia continue during the clinical interaction, but also very strongly during family visits. Personhood here is constructed on two levels. By an immediate interaction where physiological responses are interpreted as emotional reactions, and by connecting Julia's life history to a present state of being so that her surroundings are drawing on previous personhood in their interaction and assessment. Please shift slide. Julia's trajectory is contrasted by the decision to terminate Peter's neurorehabilitation and refer him to a nursing home with no specialized rehabilitation. One of the doctors explains that the permanent hold from the trajectory, as he is taken off the ventilator, makes him extra vulnerable to infections, which could lead to his death once he is transferred to standard care. In the decision-making on Peter's trajectory, his family situation also plays a role. Likewise, his previous drug abuse and diagnosis of ADHD had a constituting personhood around Peter, but with quite different connotations. Before entering his room, one of the nurses explains how his family has not been in contact with him for 5 months prior to the accident. This absence may have influenced the way the family handled the accident, as they seem very detached. It's a family of 6 children, where several are still young, keeping Peter's parents busy. In Peter's room, the rare presence of family visits is seen in withering flowers at the bedside, contrasted by the many photos of family members pinned at the board. When discussing the termination of Peter's admission at the unit, the staff refers to blended information of his previous drug abuse and psychiatric treatment, as well as the nature of the accident, which has been investigated as an attempted suicide. The staff stressed that Peter had the chance to show himself during his prolonged stay, but they don't see any progress in his condition. To support their decision of not transferring him to further neurorehabilitation, his life history is woven in with negative expectations of his brain plasticity caused by the drug abuse and the ADHD diagnosis. The personhood ascribed to Peter produces a different valuation of treatment potential. Here, the importance of societal dimensions of the construction of personhood is reflected in the story of a hard life. The social practices of constructing personhood are challenged by no one insisting on the need of a continuation of his life history. Peter is slowly fading as a person, both in an embodied, social and sentient way. Constituting personhood around Peter draws on the two levels mentioned before, the immediate clinical interaction and the recreation of his life history. In contrast to Julia, it seems that the personhood ascribed to Peter is marginalizing the few and uncertain responses that he may have expressed. And as his responses are neither clear nor systematically repeated, his potential is not established. So, what did we learn about the construction of personhood when observing the social practices taking place in a marginal situation? Firstly, the study finds that the process of ascribing personhood to unresponsive patients draws on previous life history represented through their relationship to significant others. This teaches us that personhood is socially constituted through relations which reveal the persons they produce, to cite Conrad. Secondly, the ethnographic observations demonstrate the subtleties of the clinical interaction with the patient as an interpretive practice where personhood is ascribed to one being seemingly unresponsive. This teaches us that during clinical interactions, the unresponsive patient is conceived as a sentient, social and embodied being at an immediate and limited level, directing or adjusting care routines accordingly. But practicing personhood in such a marginal space, the liminarity of the patient may be enhanced by societal tendencies that may value certain aspects of personhood more than others. Such evaluation opens up a moral and ethical reflection around the construction of personhood, which we will be happy to reflect on in the discussion. Thanks for listening.